excellent job for letting us have this wonderful webinar today. First, I would like to thank first and foremost Dr. Kanchan Sharma ma'am for selecting us as the coordinator and giving us opportunity to conduct such a beautiful webinar. I wish you all the best, ma'am, for your journey towards towards this FOXY as a person in breast committee. I will personally give this vote appeal at the end of this talk, but first I would like to express my gratitude towards you that you gave us the opportunity to me and Dr. Madhav. Thankful to Dr. MC Patel sir also for giving this wonderful platform. I would like to welcome first and foremost Dr. Kanchan Sharma ma'am. May I please have a small CV, Raj?
Yes, sir.
Yes. We are starting with a small formality, that is lamp lighting. For that, we need to have chief guests and guests of honor. I would request Dr. Kanchan Sharma ma'am to invite all the chief guests and guests of honor. But first, I would like to introduce Dr. Kanchan Sharma ma'am. Will give some few words for her. Ma'am is a laparoscopist, hysteroscopist, and colposcopist. She is an ART IVF specialist, director and chief consultant at Akash IVF Center, Kanpur. She is practicing since last 32 years. I am 34 years old, and ma'am is practicing since last 32 years. At present, she is secretary of KOGS, that is Kanpur Obstetric Gynec Society, president of IHRF Kanpur, master trainer in Dira VAH, master trainer at RSE, coordinator with Female Breast Committee. She has been awarded for Pratigya Social Impact Award, Nari Ratna Sanman Award, Corona Warrior Sanman Award, and Empowered Woman Sanman Award, Mission Shakti Nari Suraksha Sanman Award. So she has multiple awards to her head, and she is the organizer, speaker, chairperson, and panelist in various national and international conferences. So we are so fortunate to have such a knowledgeable person amongst us. I welcome ma'am to please carry on the process of lamp lighting and inviting chief guests and guests of honor of today's webinar. Ma'am is the, yes, I would not forget here that ma'am is the candidate for chairperson, Female Breast Committee. So whenever the voting lines are open for the same, everyone is requested to vote for her for candidate for chairperson, Female Breast Committee. Over to you, ma'am.
Thank you, Dr. Bhavik, Dr. Madhav, for your nice words and seeking votes and blessings for me. At the outset, my namaskar, good evening, and pranam to all the star faculties, all the masters, and all the seniors and patrons of Gujarat and Kanpur Society. This is a flyer for today's webinar. My heartily thanks to Chief Guest Dr. Alpesh Gandhi, President of FOXY, past President of FOXY, Guest of Honor Dr. MC Patel. I am very thankful to you, sir. You have guided me and took me as my mentor and guide, and you have guided how to proceed in this journey. Thank you so much, sir. Dr. Harish Doshi, he is busy, but he has accepted our invitation as a guest of honor. My regards to Dr. Neeraj Jadhav. Sir, you are very inspiring and always with us. Thank you so much for so nice. Dr. Jignesh Dilwala, President of Ahmedabad OBGY Society, Dr. Sunil Patel, President Godhara OBGY Society. Thank you to all to join us as a guest of honor today. My sincere thanks to chairperson of my talk, Dr. Usha Goenka. She just busy in some surgery. She will be joining soon within few minutes. Dr. Archana Dwivedi, President Box. I'm very thankful to you, Dr. Archana. You have joined timely, and join the academic feast and blessing us, Dr. Dinesh Patel, M. Patel, President Himmatnagar OBGY Society, Dr. Kiran Mai. Thank you so much that you have joined to us, and all the best wishes to you. Second speaker, Dr. MC Patel. Sir, you have accepted our invitation as a speaker in a short duration, and you are always a very good teacher. Thanks for blessing us. Dr. Tara Via Dhiran, President of Rajkot OBGY Society. Thank you. We hope that you will be joining soon within few minutes. Dr. Jitendra M. Patel, Dr. Praveen Kumar Duddat, and Dr. Deepa Pitre. We are waiting for all of you to join soon in our this academic feast. For panel discussion, we are grateful to our moderator, Dr. Kuldeep Singh, who's really a master trainer in ultrasound, and he is very well running the Sono schools all over India. Thanks our brilliant panelist, Dr. Manjul Pandya, Dr. Devesh Kumar Patel. I see that he has joined. Thank you so much. Dr. Jignesh Kumar Modi, Dr. Gaurav Gandhi, Dr. Jeni Kumar Chikani, Dr. Satyen Kasabwala, Secretary Navsari, Dr. Pinky Kataria, President Nadiad OBGY Society. I see that she is logged in. Thank you, Dr. Pinky. And सबसे ज्यादा तो मेरी शुभकामनाएं, विशेष and thanks to Dr. Bhavik Khatri and Dr. Madhav Hirani, two young coordinator. A big clap for them, that they have done a great job and had a great effort to organize this conference, rather I say, along with me and with the guidance of Dr. MC Patel sir. Thank you very much. So with the start of this webinar, we want to take blessings for that Almighty God. His divine power has granted to us all the things that pertain to life and godliness. Make every effort to supplement your faith with virtue, and virtue with knowledge, and the knowledge with self-control and steadfastness. That gives rise to godliness. So academic and spiritual growth, they are very good. Just actively building your life and increasing your knowledge. So Raj, can we start the lap lightning video and take the blessings? Thank you for joining us for lamp lightning. I think our chief guest, Dr. Alpesh Gandhi, has not yet joined. So our guest of honors and other guide, our mentor, I welcome Dr. MC Patel sir. we have to succeed in your mission, you must have full-heartedly devotion to your goal. This we have learned from Dr. MC Patel, sir. Work requires dedication and perseverance. So, please see. That was a bouquet for Dr. Alpesh Gandhi, sir. Dr. MC Patel, sir, he from Ahmedabad. He is a consultant obstetrician and gynecologist and medical legal counselor. He was a vice president in FOXY 2018, organizing secretary of AICOG 2017. He's a chairperson of Ethics and Medical Legal Committee from 2011 to 2013. He was honorary joint secretary, State Organization of Gynecology and Obstetrician of Gujarat in 1921, organizing chairperson of MMCon 2018, honorable member, National Inspection and Monitoring Committee, PCPNDT, Government of India 2015. He is an honorary member of State Supervision Board, PCPNDT Committee, Gujarat State in 2005 to 9. His president, he was of Ahmedabad OBGYN Society 2010 to 11, honorary member, National Managing Body, Indian Red Cross Society, headquarter 19 to 22. He is a national president of National Medicos Organization 2016 to 18 and president IMA Ahmedabad branch 2007 to 8. Organizing chairperson of Vivekanand NMO Con 2013 and honorary surgeon, Indian Red Cross Eye Bank, collected more than 1,000 eye pairs. Very nice, sir. President, Lion Club, Ghantalodia, Ahmedabad. Sir, okay, sir. Sir, you are great. सबसे ऊपर तो आपके blessings, आशीर्वाद and the guidance for which we are always indebted. Sir, your guidance is precious to us, marvelous. Sir, please come and bless with your few words.
Thank you, Dr. Kanchan, for inviting me the guest of honor in this program. Let me first congratulate you for designing this nice webinar. As far as very important topic you have chosen to discuss, adenomyosis and fibroid, because in our day-to-day practice as an obstetrician and gynecologist, it is a very common condition which we encounter in our practice. So to update knowledge regarding this area, we have rightly selected this topic and very good panel discussion also. So in this era of COVID-19, when physical meetings were not possible, of course, now it is slowly starting to have physical meetings also. But in those days, these webinars were kind of blessings to see all our Foxian friends on virtual platform, to say hello to everybody and to exchange our knowledge of any focused topic for discussion. An ultimate goal is to be helpful to our patient because they are ultimate beneficiary after all this discussion and updating our knowledge. So not taking much of your time, congratulating you again and all the best for your endeavor as far as your FOXY committee chairperson election is concerned for the post of female breast examination committee. I see Dr. Kiran Mai also on the screen. Welcome Kiran Mai to Gujarat and
thank you.
Also all the best to you for your endeavor also for a very important committee and very new committee FOXY has started this year. Say no violence to violence to women. It is a very important committee and we in Gujarat are working in this area since long. So my all the best wishes to you to take over this committee and to work in a very efficient manner. Well, of course, you are efficient as far as this particular committee is concerned. So all the best, Kiran Mai also. So,
thank you, sir. It means a lot to get your blessings today, sir. Thank you so much.
and
Thank you, sir.
without wasting much of your time, over to you, Kanchan, our Master of Ceremony.
Thank you, sir, for your nice words and blessings. These have a lot much of value in our life. Thank you, sir. Now, the time is to welcome our other most respected guest of honor, Dr. Neeraj Yadav, who has joined, I see, in a very beginning and very sincere of the time. Thank you, sir. The willingness to give a lot of time and energy to something because it is important that is what it takes an awful lot of determination, dedication, and self-discipline and effort that we see in you, sir. Welcome. You are a chairperson of Sexual Medicine Committee, FOXY 2022-23. You are a vice president, Rajkot Menopausal Society 2022-22. West Zone Coordinator, FOXY Adolescent Committee 2016.
Okay, Dr. Kanchan. No need to read all the CV. Okay.
So I see that you had many important posts and organized so many conferences. You are a contributor of various FOXY publication and faculty at national and state conference. We all need your blessings. Welcome.
But before Neeraj say something, I would like to mention for this particular committee an extraordinary work by Dr. Neeraj. Sexual Medicine Committee is a committee of FOXY since long. So many chairpersons have taken this committee. But since Dr. Neeraj has taken this committee last year, and this is his second year, he is doing marvelous work as far as this committee is concerned. And he has put this committee to such an height that his successor, whosoever comes to take chairpersonship in this committee, will have to work too hard to reach the level which Dr. Neeraj has put. So my personal congratulations, Neeraj, for doing extraordinary and marvelous work as far as this particular committee is concerned. And we are proud that Neeraj is from our Gujarat and he is doing marvelous work. Yes.
Thank you, Manu bhai. There are only three things in India that sells: sex and Shah Rukh Khan. So sex was already there, but it was not that much government committee. So luckily, with all support from so many persons, I am able to revive and make it vibrant committee. So thank you for that, for that compliment. And thank you, Dr. Kanchan Sharma, for inviting me as a guest of honor in today's webinar, conducted by Kanpur Obstetric Society and so many other societies of the Gujarat. And I was seeing the topic. It was very well chosen: adenomyosis and infertility, medical legal aspect of the fibroid, and ultrasound and fibroid. So very nice and clinical topic you have chosen for today's webinar. So I wish a great success for today's webinar. And there are so many presidents and secretary here as a faculty. So I'm saying that Dr. Kanchan Sharma is contesting for the female breast committee. So we all should support. She is a very sincere and hardworking member of the FOXY, and I'm sure that she will do a great justice to this committee. And we have another Dr. Kiran Mai. We are seeing her since last 2-3 months. She is everywhere, doing so many school workshops about the Santa Kumari Madam's project. And I wish everyone also support her, Dr. Kiran Mai, for her committee, that is a Violence Against Women Committee. We all are seeing her work, how dedicated she is in her effort. So thank you and best of luck to Dr. Kanchan Sharma and Dr. Kiran Mai, and best of luck for today's success for this webinar. Thank you.
Thank you so much, Neeraj sir.
Thank you, sir. Thank you, Neeraj sir, for your excellent words and good wishes. I think your wishes are always a boon for us. Thank you so much. Now we welcome our next guest of honor, Dr. Sunil Kumar Patel. Sir, we welcome you as a guest of honor. Thank you that you have joined us. And Raj, please show CV of Dr. Sunil Patel. Raj, please CV of Dr. Sunil Patel. Raj from Shield. Yeah. We welcome Dr. Sunil Patel. His nickname is SP. He is a president of Godhra Obstetrics and Gynae Society, Navjeevan Hospital. He was a state vice president of Indian Medical Association, GSB 2008. He's the president of Godhra Obstetrics and Gynae Society from 2016 to 20, secretary of Godhra Obstetrics and Gynae Society 10 to 12, and many posts, secretary in Indian Medical Association and Central Working Committee member, Indian Medical Association, New Delhi, and district coordinator of Mahisagar and TB initiative program, zonal representative of South Zone, and he is a gynecologist and laparoscopic surgeon running Navjeevan Hospital since 1992. He is a laparoscopic TL panel surgeon at various government hospital in FP camp, and he attends all the state, national, international conferences, as I have seen that he has joined very early in this webinar. This shows his interest, and he passed MBBS in 1986 and DGO in 1988. So he is a very brilliant, very good fellow. I welcome you, sir, and want to take your blessings in this. Welcome, Dr. Sunil. This is a bouquet for you, virtual bouquet for you, sir. Dr. Sunil, few words. You have to unmute yourself.
Thank you very much. Very interesting webinar is going on. So without wasting much more time from me, I request the faculty to continue on. I am thankful to and congratulations to all the organizations, especially Dr. Kanchan Sharma Madam, our beloved Dr. MC Patel sir, and all the MOC and all the faculties who are taking part in this interesting seminar, which is very important in day-to-day practice. Thank you very much, and I wish you all the best for the further of this webinar. Thank you.
Thank you so much. I think our next guest of honor, Dr. Jignesh Dilwale, has not joined us. Dr. Bhavik, hai kya wo? Dr. Jignesh Dilwale?
No.
You may continue with the program, and whenever Dr. Jignesh joins, you may have words from him.
Yes, definitely.
So now again I am giving hand over mic to Dr. Bhavik and Dr. Irani for further proceedings. As we say that practice is an essential factor for mind management in all the field of human endeavors. So practice is the key that opens the door for mastery and excellence. So we go on practicing these topics, hearing again and again. So the mic is to you, Dr. Bhavik. And
yes, ma'am. Thank you. Thank you very much. After this small formality of this webinar, we are proceeding towards the actual academics, that is regarding adenomyosis and infertility. This topic will be covered by Dr. Kanchan Sharma herself. The chairpersons of this particular session will be Dr. Usha Goenka, Dr. Archana Dwivedi, Dr. Dinesh Patel, and Dr. Kiranmay Devinemi, ma'am. May I request Raj to please show us the CVs of all these chairpersons so that I can introduce them. Raj, may I have the CVs of the chairpersons of the session by Dr. Kanchan Sharma, ma'am? Yes, Raj is connecting. Thank you. The first chairperson with us is Dr. Usha Goenka, ma'am. Ma'am is the life member of Indian Menopausal Society, ISPHE, ISOPARB Kanpur. She is vice president of KOGS 2019 to 2021, secretary of the same society in 2012 and 14. She has been executive KOGS for many years. She is specifically trained in IVF and infertility of Institute of Reproductive Medicine, Kolkata, and has passed a learning program in medical law and ethics of NLSIU Bangalore. Welcome, Dr. Usha Goenka, ma'am. I just hope that she will join in a few time. The next person with us is okay, next slide. Next chairperson with us, who has already joined, is Dr. Akshana Vedimam. Ma'am is the president of BOGS 2021-22. She was president of VMS 2019 and 20. She has keen interest in high-risk pregnancy, laparoscopy, vaginal surgeries, and DVH. She is faculty of adolescent counseling and menstrual hygiene awareness and anemia eradication program. She is West Zone coordinator. Yes, she is West Zone coordinator for breast, adolescent, and safe motherhood Foxy committee. Welcome, Archana Dwivedi, ma'am. Yes, we can go to the next slide. Yes, thank you. The next chairperson is Dr. Dinesh Patel, sir, from Himmatnagar. Sir is the president of Himmatnagar Society. He is the director and consultant obstetric gynecologist in Vardhan Women's Hospital. Sir is the president of Himmatnagar OBGYN Society, organizing chairperson of 70th annual conference by IMA, and sir has received Gujarat Gynec Excellence Award West on Yuva Foxy in 2020. Welcome, Dinesh Patel, sir. Yes, we can move to the next slide. Raj, next slide, please.
ये next आ गया डॉक्टर किरण भाई.
Yes, thank
Dr.
you. But
Kiran.
and last but not the least, yes, last but not the least, chairperson of this session, Dr. Kiran Devineni, ma'am. Ma'am is the coordinator of Foxy Dira Initiative, Stop Violence Against Women 2021 to 22. She is vice president and secretary of OBGYN Society of Hyderabad from 2016 to 19. She is chairperson of Adolescent Health Committee. Ma'am has got Yuva Foxy Orator Award and has multiple publications to her credit. Welcome, Kiran Devineni, ma'am.
Thank you,
I
Dr.
would
Bhagat.
request Dr. Yes, ma'am. I would request Dr. Archana Dwivedi, ma'am, to have a small introduction of Kanchan Sharma, ma'am, in the beginning. Move on to the next slide, Raj.
Thank you so much, Dr. Bhavik, for giving me this opportunity to introduce Dr. Kanchan Sharma, madam. She looks like a pillar and with so many awards in her kitty and such a dedicated person. I would like to congratulate in advance both the ladies who are so young and forever working for the society. Dr. Kiran Mai is here and Dr. Kanchan Sharma, madam, and wish them all the success in this Foxy endeavors. And especially when I talk about Kanchan Sharma, madam, our wholehearted support, I would also appeal vote for her while she's contesting as a chairperson of Female Breast Committee for this year. And as we all know that she is having so many awards in her kitty, especially Nari Ratan Samman, Corona Warrior Samman, and WWW Empowered Women Samman Mission Shakti Nari Suraksha Samman. She is presently Secretary KOGS, and believe me, ma'am, UP and Kanpur is very close to my heart. I am myself a graduate from Allahabad University, so it gives me immense pleasure to be here with you all. And I think the topic which you have taken to talk today is adenomyosis and fertility, a very less understood topic, but a very important scenario when we talk about the infertility patients. As you'll unfold the topic in the coming slides. I know it has got indirect proof by preventing the implantation, the endometrial receptivity, and with the increasing age of the women in our country for getting pregnant, it is a very important point to discuss the infertility which is associated with adenomyosis. As more the age advances, it is usually associated with endometriosis, pelvic endometriosis as well. So I think a very apt topic taken by you today, and without wasting much of the time, I think we will like to listen from you that what the history unfolds and what is the treatment modality and how should we proceed when we have such patients with us. Over to you, Kanchan ma'am. It's an honor to be here leading your session.
Should I share the slide? Thank you for the nice words. My slides are visible.
Yes, ma'am. Please put it on the show mode.
Yes.
It
It is starting being visible.
Yeah, ma'am.
Yeah. Thank you for nice words. My sincere thanks that I have already shown this slide. Rather than having I'll start with the introduction of adenomyosis. Then we will switch on the case presentation, because as you said that adenomyosis is a benign disease of the uterus characterized by ectopic endometrial glands and stroma within the myometrium. It is associated with the myometrial hypertrophy and may be either diffuse or focal. If we do the pelvic examination, there may be uterine enlargement. We can feel soft and boggy uterus on pelvic examination, and sometimes this condition may be associated with leiomyoma, may be associated with endometriosis, endometrioma. Repeated bimanual examination over the several months just before and after menstruation have been recommended to detect the fluctuation, changes in contours, size, and consistency of the uterus. Because initially we see that the diagnosis of endometriosis was very difficult, and we make this diagnosis after the hysterectomy specimen has been visualized. So this is a normal, and this is the adenomyotic uterus. But with the advent of time, with the most recent mode of diagnosis, we have by the ultrasound, by the MRI, by many other methods, which I will come in the coming on slides. We have started with the conservative treatment and taking its role in the infertility. Since adenomyosis term was described by Rokitansky in 1860. Since then, this bothering to gynecologists regarding its varied presentation, as this is the era of improved ART and IVF services. And with improved diagnostic tools, we gynecologists are bothered that whether adenomyosis may be a contributing factor in infertility or even in the ART in cases of ART failure. It may be having a role. So rather than going in a routine way, I'm presenting a case just to make it interactive and interesting. A patient, Mrs. Neera, aged 35 years, primary sterility with no obvious cause detected. She presented for IVF treatment. She had a history of dysmenorrhea, menorrhagia, for which routine HRT, routine hormonal treatment was given, but patient was not responding to that particular treatment. In this patient, we did ultrasound. And ultrasound, especially the TVS finding, because ultrasound is now most important, and we have in our OPDs, nearby room of my OPD, I have ultrasound, and it's very easy for me to do ultrasound and TVS in patients. So in this patient, TVS of the uterus in sagittal plane, a case of focal uterine adenomyosis, showing focal heterogeneity along the interior wall with a small cyst like structure. See this, that was visible, and heterogeneous myometrium with hyperechoic linear striations. Ye hyperechoic linear striations which are visible, these are the features of adenomyosis in ultrasound. In color Doppler of endometrial gland inside the endometrium, color Doppler mein, you can see these type of endometrial glands. Dr. Kuldeep Singh is here. He is ultrasound and specialist in 3D ultrasound, because now there are more latest diagnostic methods. Voluson ultrasound machines are there. We can do 3D ultrasound of the uterus. So this showed uterus in the coronal plane, focal adenomyosis at many places of the inner myometrium, and junctional zone that was found to be interrupted with hyperechoic areas in between. Junctional zone, TS zone is increased. We see that more than even 12 mm in these cases. Then we advise MRI of this patient. MRI findings of Mrs. Neera showing a huge globular uterus like this was shown in this diagram, containing multiple endometrial foci related to deep diffuse internal adenomyosis. This type of the picture is being shown in MRI. And you can see ill-defined areas of low signal intensity in MRI and broadening of junctional zone due to smooth muscle hypertrophy associated with invasion of the endometrial gland visible in MRI. Junctional zone usually, when seen in this case, is more than 12 mm, which is widened, and an important finding in case of adenomyosis. Junctional zone बहुत important है, that we should always see the junctional zone. By these improved diagnostic modalities, we could make the diagnosis of adenomyosis in this patient, which because of numerous factors may result in primary infertility and IVF failure, because that patient was a patient who undergone IVF treatment also, and so many treatment, but she had a failure. Now she presented to me. After routine basic investigations and improving her hemoglobin, we planned for 3-month course of GnRH agonist and debulking surgery for the patient. So coming on a short literature, what are the conservative surgery for adenomyosis? The conservative surgery for adenomyosis can reduce symptom and raise the pregnancy rate significantly. It can be accepted by young women who want to preserve their reproductive capacity. Though the pregnancy rate of conservative surgery for diffused adenomyosis was low, it still has a therapeutic value. There are multiple methods for conservation of fertility sparing surgery for adenomyosis have been performed with subsequent pregnancies. These techniques, they include classical adenomyomectomy, H-incision, triple flap method, and laparoscopic cytoreductive surgery. Adenomyomas are less distinct with absence of well-defined borders and given protrusion into the myometrium. तो अभी हम इसमें दिखाएंगे, बात करेंगे in the coming. Even I have some videos that we do debulking. During dissection, the plane is identified and mainly recognized by the healthy myometrium. So simple enucleation is somewhat difficult in these cases, but we do debulking. Sometimes there is increased intraoperative bleeding too, and we have to stitch in 3 layers. This is a picture of surgical resection. This is a video of operative debulking surgery. We have given incision. Very short video of 30 seconds, just I have. This we are giving incision and doing enucleation. some focal endometriotic tissue may be removed, or we may do debulking. I am forwarding the video. This we have taken. We did the debulking. And now we are stitching it up. We are taking the stitch. So this patient was also having, many times they are also having endometrioma along with this. This is a 2 week after the surgery, ultrasound picture of the uterus. 2 months and 3 months after the surgery. So how does adenomyosis affect the fertility? The proposed mechanism for infertility in the patient with adenomyosis focus on derangement of the 3 putative pathways. It is said that it is hypothetically taken that it affects the uterotubal transport, endometrial receptivity, and the implantation. Uterotubal transport is impaired due to intrauterine anatomical distortion. It is said that endometriosis that distorts the anatomical situation and position of the uterus, that blocks the tubal ostia and potentially blocks the sperm migration and the embryo transfer. Uterine hyperperistalsis has been seen on the ultrasound in the patient with adenomyosis due to destruction of the normal myometrial architecture. These abnormal myometrial contraction wave led to abnormal sperm transport through the uterine cavity and may also lead to increased intrauterine pressure. So it is said that it causes derangement of the uterotubal transport. And even because as we see that adenomyosis that causes abnormal inflammatory response, so obstetrics and gynecological survey that reports that people with the adenomyosis were found to have a greater density of macrophages which produce pro-inflammatory cytokines and reactive oxygen species. This, as we see, always discuss in fertility specialists that these ROS, they are always toxic to developing embryos. So that is again a theory that because of this, our fertility treatment procedure may be affected in adenomyosis. So understanding how the adenomyosis and infertility are related can help the clinician to inform their patient of all the possible treatment options. So, establishing the diagnosis of endometriosis is now being very important and more feasible because of availability of some latest methods like improved ultrasound machines and MRI technology. It is said that endometrial receptivity and the function that also become altered in adenomyosis via increased production of estrogen from aromatization of androgen and altered estrogen receptor, progesterone receptor expression. The inflammatory response in the woman with adenomyosis has also been shown to be increased, as we have just discussed. Lastly, the impaired implantation from a lack of adequate expression of adhesion molecule, reduced expression of implantation markers, and altered function of gene for embryonic development, that all are there. Because of this, adenomyosis has not, but still, it is said that as we had a clear-cut concept about the endometriosis that affects the fertility, the concept about the adenomyosis has not yet been shown to have an adverse influence on oocyte function or folliculogenesis, but it definitely affects endometrial receptivity and the tubal transport. Other diagnostic methods which we can do is the sonohystrography, that is put a dye and do the ultrasound. Histography, filling of the cavities in the uterine wall during the histography was observed in 54 of the 320 surgically excised specimen in which metal thread had been inserted at the different level for the identification. So this may be a diagnostic method. Myometrial biopsy, laparoscopically or sonographically guided, can be done. Myometrial biopsy can be because by biopsy we can see and have a frozen section facility and can go into the diagnosis, but these are not because invasive procedures. CA-125 is also a method to diagnose that is increased but not very conclusive. If we do the hysteroscopy, we can see this type of picture of the endometrium. At many sites, there may be this type of pictures which show the endometrial invasion into the myometrium. Coming on the management aimed at the goals, if we talk about the infertility, there should be, first of all, conservative treatment and treatment directed towards the cause. If there is pain, as we see that in this patient, there may be history of pain and menorrhagia. So treatment should be directed towards that. Fertility preserving, symptomatic medical conservative surgery, or the radical surgery in cases the patient is not being relieved with all these methods and have the children. Other methods are intrauterine LNG like Mirena, Danazol, progesterone, GnRH analogs, and few latest method which I'll be discussing just now. There may be high frequency ultrasound directed surgery. Surgical approach, which we have discussed, laparoscopic myometrial electrocoagulation can be done, localized excision can be done, or uterine artery embolization can be done in few cases, laparoscopic uterine artery ligation, endometrial ablation, or at last is hysterectomy. The only definitive treatment for adenomyosis is total hysterectomy. That can be done in a patient who already have completed her family and have a history of menorrhagia, not responding to normal progesterone or other treatments. So frequently it is moderately, if the uterus is moderately enlarged and asymptomatic, then no treatment in this case is necessary. Temporary relief by the painkillers or GnRH agonist we advise. Pain management with NSAID can be done. Severe pain and heavy menstrual bleeding case. There is a case presentation who has a severe pain and severe bleeding per vagina. She was a patient of 40 years old woman, has been because of a history of 10 years of the severe menstrual pain and excessive bleeding lasting 10 days of each month. She was obviously anemic. She had a she had consulted many physicians, had several ultrasound studies and laparoscopy. She was told that she had multiple fibroids and that a myomectomy was impossible. Recently, a physician had told her that any such attempt would be a bloody mess and inevitably resulting in hysterectomy. On examination, her uterus was enlarged to the size of 16 weeks pregnancy with a prominent swelling involving the upper uterus. On high resolution transvaginal ultrasound, a 9 centimeter tumor was identified, but its boundaries were ill-defined and appearance suggested an adenomyoma more than a fibroid. This is very important for the DD point. The patient was told that if it was a fibroid, it would be removed with an excellent chance that she would be able to conceive in the future. However, she was informed if in fact surgery revealed an adenomyoma, resection would solve her medical problem, but her uterus would be missing significant portion of its muscular wall, precluding future pregnancy. All the findings were told her and she was counseled at surgery. She was found to have adenomyosis confirmed during surgery by the frozen section pathology evaluation, and adenomyomectomy was performed with the reconstruction of the remaining uterus. Blood loss was minimal and post-operative recovery was good in this patient. 1 year later, she reported that she has very little regular periods lasting for 3 days and she has no pelvic pain. And later on, she wanted to conceive and she conceived and had a successful pregnancy. Other methods which we can use is Marina, this LNG IUS. In many cases, if we want to have a conservative treatment, we can have benefit. Gonadotropin releasing hormone analog have very important roles, but it is effective in reducing the adenomyotic uterus and may facilitate pregnancy. But in long-term use, it can cause a bone loss, so not used for long-term time. Surgical resection with GnRH treatment is another way which we can adopt, because by GnRH, initially we give 3 months GnRH treatment, then we can have a surgical resection of excess adenomyotic. 2 other novel approaches are some anti-angiogenic agents are there, which can be used for adenomyosis. These are some latest approach in which we can use even pentoxifylline 800 mg twice a day, that also have a anti-angiogenic effect. Some other factors, xenoestrogen, have a theory also. In that we see that these same chemical estrogen, xenoestrogen, that are causing early puberty in the girls are now being blamed as the cause of adenomyosis as well as endometriosis, even breast cancer and the cervical cancer. So work in these lines is required. So still, after so many options, there is a dilemma and frustration of an ideal treatment for adenomyosis. It persists especially in the woman where uterus has to be conserved. So in conclusion, I can say, although adenomyosis is a common gynecological disorder, its role in infertility is still unclear. It previously was believed to be a symptomatic disease in older women, but it is now being seen in an asymptomatic and younger population undergoing evaluation of infertility. Limited studies found an association between adenomyosis and the poor reproductive outcome. However, other coexisting pathologies such as endometriosis may be significant co-founder in these cases. Thank you very much for patient hearing and giving me chance to express my views. Now, I will be needing our chairperson's views regarding adenomyosis.
Thank you. Thank you
I
so
would
much.
request,
Yeah.
yes. Kiranmai ma'am will
Yeah.
say some words about conclusion. Yes.
Thank you, Dr.
Stop sharing.
Bhavik. Yeah. Thank you so much, Dr. Kanchan, for this very well designed and important program. And your talk was really excellent, covering all the aspects of adenomyosis and infertility. And your expertise in the field of both infertility and endoscopy is like, I've listened to you in the panels before also. And you're a very able administrator and a very dynamic personality. And I wish you all the very best in your all your endeavors and future in Foxy and your committee chair election also. And let me thank you and Kanpur Society and Dr. Alpesh Gandhi sir, who is our chief guest, Dr. MC Patel sir, Dr. Neeraj Yadav. It was a pleasure to be here almost, though virtually in Gujarat. So a special day for me also. Thank you for making me part of this program. And I extend my thanks to each one of you all the presidents and secretaries of Ahmedabad, Baroda, Junagadh, Porbandar, Bhavnagar, Rajkot, Jamnagar, Anand, Palanpur, Godhra, and Navsari societies. Thank you so much. And I also request you to support me and vote me for what Sir Patel sir has already told, No to Violence Against Women Committee, new committee as chairperson. Thank you so
Dr.
much,
Kiran,
Dr. Bhavik.
for your
Yes,
nice words and good wishes to you also.
thank you. Dr. Bhavik, over to you.
Yes. Thank you very much, ma'am. It was truly a wonderful session by Dr. Kanchan Sharma, ma'am, regarding adenomyosis and infertility. Excellent coverage of all the academic information. I would request Dr. Madhav Hirani, sir, to carry on this session of Dr. MC Patel, sir. Madhav, are you with me?
Yeah, thank you so much, Dr. Bhavik Khadri, and thank you so much for the to Dr. Kanchan ma'am for the informative session. Moving on to our next session, the topic would be the medical legal aspect of fibroid. Can I have the CVs for the chairpersons, please, Mr. Raj? So we have the chairperson for the next topic, Dr. Tarvaria Dhiren. He is the president of Rajkot Obstetric Gynec Society. He has done his MBBS and MD from Uterine Hospital and MP Shah Medical College, Jamnagar. He is doing private practice since 22 years. He has delivered many lectures and panelists in Rajkot OBGYN Society. He is an EC member of SOGOK 2014. He is the president of present president of Rajkot Obstetric and Gynec Society. Our next chairperson is Dr. Jitendra Patel. Dr. Jitendra Patel, he is a consultant and obstetrician and gynecologist, IVF specialist. He is MCA permanent. He's been practicing at Priya Hospital and IVF Center. He is working as a joint secretary and one of the organizing secretary of annual SOGOK at Anand in 2010. And he has served as a Foxy Anand for 4 years and now president of Foxy Anand Society since 3 years. He has attended several national and state conferences. He has been trained in laparoscopy, training at Foxy, recognized like by Dr. Shailesh Putambekar sir. And he is right now working at Priya Hospital and IVF Center. We welcome you, sir, to today's webinar. Our next chairperson, Dr. Praveen Dudat sir, a laparoscopic and IVF specialist. He is the director of Unique IVF Center, Junagadh, current president of Junagadh Obstetric Gynec Society, past secretary of Junagadh Gynec Society. He is the first one to do laparoscopic vaginoplasty in Saurashtra region and the laparoscopic ureteric reimplantation in Saurashtra. He is the first one to get 3D 4D fetal medicine center in Junagadh. We welcome you, sir, to today's webinar. And our next chairperson, Dr. Deepa Pitre Madam, the secretary of Vadodara Obstetric and Gynec Society. He is an associate professor at GMERSCM Medical College. We welcome you, ma'am. Today's speaker for the topic medical legal aspect of fibroid. Dr. MC Patel, sir. As we all know that sir doesn't need any introduction. First of all, I'll just start at that he's the mentor for us, and he's guiding us throughout the journey. He's Vice President Foxy 2018.
Madhav, already introduced, so no
Yes.
need to repeat.
Yes, over to you, sir. You can please.
Thank you. And let me, please allow me to share my screen. Organizers? Yes. Is my screen seen, full screen?
Yes, sir. Yes, sir.
So, greetings from Statue of Unity, and it is tallest statue of world, and we all are proud of that statue. Today's topic, legalities in fibroid and myomectomy. So, management of fibroid and how it may end up into litigation. Let us see how it ends. Warm welcome all the delegates and wishing you a litigation-free practice. At the outset, I would like to thank Dr. Kanchan Sharma for inviting me to share my views about the subject and all the societies who have joined this webinar. Usually, I start my talk with this question: is it worth discussing? And if it is yes, then why? So, see the statistic. This is statistic of Professional Protection Scheme, which is run by IMA Gujarat State Branch, and see the figure of 2017. Total enrolled members were 11,979, and out of those 2,359 friends were facing litigation in one way or other at district forum, state commission, notice levels, national commission, Supreme Court, criminal cases, civil cases, and see the increasing number of membership as well as number of litigations. So last year only 16,485, and out of those 3,113 members were facing litigation in one way or other. So it simply, if we calculate, then it comes to 18 to 20%. So it is a serious matter. So medical litigations are increasing in number constantly and steadily, and unluckily we gynecologists rank first as far as these medical legal consequences are concerned. So which are the areas for litigation and which are the treatment options as far as fibroid management is concerned? Medical part, uterine artery blockage that involves cutting off blood supply to fibroid. Surgical, it could be myomectomy or in few of the cases hysterectomy. And as far as hysterectomy part is concerned, minimally invasive surgery or laparotomy or vaginal route. Radio frequency ablation, the insertion of small instrument that cause necrosis in fibroid through emissions of radio frequency emissions, and it could be combination of more than one modality of treatment. So these are the areas as far as our treatment plans related to fibroids are concerned. So which are the areas for litigation? Delayed in diagnosis. Many times when it is delayed in diagnosis and if patient suffers a lot, then in court of law, it would be the one of the allegation. And whenever this type of situation one is facing, then in court of law, very important question comes that was it preventable? That delay of diagnosis been avoided? So if it is yes, then what did you do to prevent it? One more question, why you couldn't prevent it? If you couldn't prevent, then this question will also be answered in court of law. Did you diagnose in time? And very important question, did you manage way in which any prudent doctor would have managed? So if you can answer all those questions, then you could be out of problem. Which are the other area? Let us see one very interesting case which was decided in one of the court. It was case of dysmenorrhea, pelvic pain and infertility, and diagnosis was multiple fibroids. Endoscopic management was advised, and after due surgery, patient was fine post-operatively and patient was discharged. After 2 years, Same complaint, dysmenorrhea, pelvic pain, and still her problem of infertility was also existing. So case was filed, an allegation of reoccurrence. An allegation was no proper care taken to avoid reoccurrence. And we know, it is known with any of the case of fibroid that it may reoccur. So again, all those questions will be asked in court of law. Was it preventable? Was this recurrence was preventable? If it is yes, then what did you do to prevent it? And if you couldn't prevent, then did you diagnose in time? And again, the main and last question, did you manage way in which any prudent doctor would have managed? So these are one, this is one more area as far as litigation part is concerned. One more area, damage to vital organs. When you are dealing with any surgery related to fibroid, it is all likely that there could be damage to some vital organs like important blood vessels or urinary bladder or ureter or so. So in this type also, again, same bunch of questions you will have to answer. And as far as this part is concerned, what did you do to prevent it? Could you prevent damage to the vital organ during dealing with the case of fibroid? So let us this very interesting case. Julia, she was travel consultant. Pain and infertility was her problem. She was investigated and diagnosed as a submucous fibroid in uterus. Hysteroscopic myomectomy was planned. Much of fibroid had been removed with hysteroscopic route, and still surgeon continued with the surgery, and ultimately it ended into uterine perforation, and rent was almost 2 to 3 centimeters. Resectoscope damaged the blood vessel supplying the rectum, and there was massive blood loss and almost 6 liters of blood, and so immediate laparotomy was needed to control bleeding, and colostomy was done because there was injury to major blood vessels supplying rectum part. So colostomy was done, and she suffered chronic pain, difficulties in returning to work as a travel consultant, and her problem of infertility was still continued. So she was a doctor, and case was filed. So allegation on part of Julia was, it was negligence on part of treating doctor. So it ended into perforation of uterus and vascular and bowel injuries, too large to be removed without laparotomy. So why this route of hysterectomy, hysteroscopy was chosen? Moreover, when the surgeon had removed almost 80% of fibroid, he should have stopped the operation because the risk of uterine rupture was too high, and Julia had to undergo numerous procedures as a result of this damage, colostomy, reversal of colostomy, and her infertility part was still continued. So notice was served and case was filed. So as far as hospital part is concerned, hospital denied the liability, and strong expert evidence in support of the case. Matter was fixed for trial in February 2006, and eventually, after exchange of expert evidence, the defendant admitted liability and apologized for the mistake and on part of treating doctor, and case was settled with 300,000 pounds plus cost. It was case in foreign country. The case was conducted on a no-win, no-fee basis. So this is serious matter, because in this particular case, advocate offer patient that she will have to pay nothing if she loses the case, and if she wins, then only she will have to pay her fees as a some percentage of the amount settled. So area for litigation in management of fibroid is one more area, that is damage to vital organ. And again, all those questions will be asked. Was it preventable? Yes. Then what did you do to prevent it? Why you couldn't prevent it? Did you diagnose in time? If at all there is injury, and if you can diagnose in time, and if you can manage very nicely, then also there is some scope for defense. But if goes unnoticed as far as damage of vital organs are concerned, then it becomes very difficult in court of law to face this type of situation. Somewhat as far as power morcellation is concerned. In past, women who had hysterectomies and fibroid removals with power morcellations filed a lawsuit against manufacturer after they claim the device spread uterine cancer. So after morcellation, there were cases of advanced case of uterine cancer, and a case were filed against Johnson & Johnson company who manufactured morcellator. And Johnson & Johnson, with this case, withdrew 3 of its devices from the market, and litigation is going on. So far, Johnson & Johnson has settled several cases for undisclosed amount. Women who had minimal invasive hysterectomy and fibroid removal with laparoscopic power morcellator later found out they had an advanced stage of uterine cancer, and these women and their families filed a lawsuit against device manufacturer, claiming the company never warned them that power morcellators could spread hidden cancer cell. So US Food and Drug Administration issued a safety communication in April 2014 and discouraging doctors from using these devices to remove uterine fibroid because the risk of spreading undiagnosed cancer throughout the abdominal cavity. Shortly after, Johnson & Johnson pulled its laparoscopic power morcellator sold by its Ethicon division from the market, and after FDA issued warning, a number of insurance companies stopped paying for morcellation surgery. So insurance companies were also in a line that if any surgery is done with morcellation, they will not entertain claim, and hospital chains were banned. But it was too late for many women already affected by the device, and after several women died from aggressive uterine cancer such as leiomyosarcoma, and their families filed a wrongful death lawsuit. So as far as this risk of undiagnosed cancer part is concerned, there was retrospective study, and Rigel et al. In retrospective analysis of women who underwent myomectomy from 496 centers in USA, identified uterine cancer in 1 into 528 women who underwent myomectomy without power morcellation, and 1 into 1073 who underwent power morcellation. The rate of any pathological finding of any cancer was 0.67%. One more study in National Norwegian respective study saw leiomyosarcoma at 0.86 in 100,000 women and 0.3% of women who had a hysterectomy. National study from Netherlands, leiomyosarcoma to be 0.25% or 1 into 1,400 women, and incidence of unexpected leiomyosarcoma was 0.12% or 1 into 865. So American population-based study was of women undergoing hysterectomy. The incidence of unsuspected sarcoma was 0.13%, and undiagnosed sarcoma in women with fibroid 0.35% of premenopausal women and 0.57% in postmenopausal women. And overall incidence of leiomyosarcoma was low, and however the incidence increased with increasing uterine weight. So 0.03% among women with uterine weight less than 250 grams and 15.4% in those with a uterine weight more than 2 kg, 200 grams, 2 kg. So it has direct relation with the size of uterus. And there were some limitations as far as power morcellation is concerned. Uterine sarcoma, including stromal sarcoma and leiomyosarcoma, can mimic benign fibroid and are difficult to diagnose preoperatively. Fibroids cannot be biopsied directly due to concern about bleeding and sampling error. Additionally, endometrial biopsy will only detect sarcoma in 30 to 60% of the time, presumably when the sarcoma is eroding into endometrium. And so negative biopsy doesn't rule out sarcoma, and MRI in combination with serum level of lactate dehydrogenate isozyme 3 predicted sarcoma, but that has not been replicated in other centers. So further it was added, minimally invasive surgery is commonly used for hysterectomy because of its many benefits over open surgery. Although small uteri can be removed whole in this approach, larger specimen must be morcellated, but power morcellation has come under scrutiny because of a concern that it can disseminate occult uterine sarcoma, other undiagnosed malignancy, and benign tissue. So to limit uterine tissue dissemination, morcellation can be continued within a bag. So it was suggestion with all these cases. And in addition, a careful preoperative workup should be performed to minimize the risk of occult malignancy. So these were the guidelines given by USA, FDA, USA. As far as lower segment cesarean section with myomectomy is concerned, because many a time during cesarean section, we find big myoma, and many times so many of our friends are used to remove myomectomy, myoma with myomectomy. So many times, as far as legal aspect is concerned, can one do myomectomy with lower segment cesarean section? Yes or no? So if prior consent is taken, and if you are readily available to deal with situation with blood transfusion and with all facility, and if you have enough experience to deal with situation, then of course you can very well go with myomectomy during cesarean section also. But if you have not taken consent, then you cannot remove myoma unless it is life-saving. If there is profuse bleeding and if it is very immediately necessary to save life of patient, then even without consent, you can also very well go for myomectomy. But it should be immediate danger to life if not removed. And burden of proof is always on your shoulder to prove that it was dial emergency and it was very immediate necessary to save life of patient. So just I mentioned, there should be all the facility to deal with the situation. You should have enough experience for cesarean myomectomy, and blood and blood products should be ready, and prior consent is very much must. In this famous case of Samira Kohli versus Prabha Manchanda, concept of consent in India was described, and in that criteria, it was also mentioned that there can be a common consent for diagnostic as well as operative procedure together. And one more part was added, particular surgical procedure and additional or further procedure. So if you are dealing with a case of cesarean section, and if you have to go for myomectomy, then common consent can be taken for cesarean section as well as after delivery of baby, myomectomy. So this is already given in that particular case. But as far as fibroid management as a whole is concerned, every complication related to fibroid management are potential threat as far as medical legal consequences are concerned. And many times we have a question, looks like avoiding medical legal problem in our practice is a difficult balancing act. No, not at all. Then what to do and how to prevent? So practice foreseeability, that is anticipation, good communication and proper consent and proper documentation, and you will be simply sail through. As far as foreseeability is concerned, law or any court expect from you to anticipate certain complication in any given situation, in any given surgery, not for fibroid only. But when you are dealing with a case of surgical management of fibroid, naturally you should anticipate probable complication, and you should be readily available to deal with the situation with any other procedure or intensive care, or possibility of blood transfusion should also be anticipated. So if you are well aware of all this, and if you are readily available to deal with the situation, then you are out of problem. But proper counseling is very much important, because it is very obvious. More is the time you spend with the patient in consulting room, less is the possibility of needing to spend time with that patient or relative in courtroom. So communication is key to avoid litigation, and it is very obvious. We might have the best medicine in the world, but it won't be successful if patient doesn't understand it. So proper communication with the patient and relative is very much important. And as far as our counseling is concerned, usually we start like this. What is the complaint? And there are so many questions on part of patient. Why did it happen? How it can be avoided? Will it happen again? Could it have been avoided? So there are so many questions on part of patient. But at the time of counseling, we are under obligation to explain about all the alternative modalities of the treatment in given situation with its probable morbidity, probable expense, in few of the cases, possibility of mortality also, probable prognosis, probable complications, possibility of blood transfusions, risk involved, and in few of the cases, possibility of malignancy should also be explained if at all you are suspecting, and possibility of recurrence, and it should be in a very common language, simple language, no much medical jargon. You should explain it in a language which patient can understand, and no rosy picture about result, no tall claim about result, because in eye of law, when you claim to be master, then you are supposed to be master. And in our practice, many times we consider our result like Aishwarya Rai, but it may turn like this at any time. So no tall claim, no rosy picture about result. So proper communication with the patient is very much important, and documentation. When you have a signature on consent form, it becomes a documentation of your communication. Because in one famous case of C. Jaipal Reddy versus Padmini Velluri, National Commission has very specifically mentioned that consent paper is not mere piece of paper where patient or relative has to sign, but it is an important document of your counseling, of your communication with the patient and relative. Whatever you have counseled about your surgery or about your procedure you are going to go for, it is a very important document. And once patient signs it, it is believed in eye of law that whatever written above was explained to her, and she was agreed with all, and then only she has signed the document. And whenever you offer all those documents in court of law, it becomes a communication of your documentation. But in all these cases, records are always at your rescue. So keep them up to date. What was done, nothing was neglected, and given treatment fully met with standard demanded by law and ethics. And it should be easily acceptable whenever offered in the court. Because a doctor is bound to produce record whenever asked by the court. And if he doesn't, then adverse inference might be drawn. And it is very obvious. Good record is good defense. Poor record is poor defense. And naturally, no record is no defense. And it has been my experience during my medical legal practice. We doctors' friends are very poor as far as record keeping is concerned. And as far as this COVID-19 era are concerned, now we are lucky that it is slowly going. But in those areas, at the time of counseling patient or taking consent, we should explain all possibility of spread from patient to others, from others to patient, with all its precautionary measures. And at the time of taking history of international travel, interstate travel, history of contact with COVID positive patient, contact with suspected COVID positive patient, any history of quarantine, either home or hospital. And if at all she turns out to be positive for COVID-19, then please inform appropriate authority as per government notification. Because after this COVID era, few of our friends are facing litigation only due to that allegation that when it was case of COVID-19 positive, then why you didn't inform appropriate authority, and they had been served with a notice from appropriate authority. So in this type of situation, it is very much needed. And if your hospital is recognized to deal with a patient of COVID-19 positive patient, then you can deal case at your place, or you will have to refer patient to respective center for further treatment. So have some basic legal knowledge and always obtain medical legal advice whenever you are in doubt. There is always a way, and in spite of all this professional and occupational hazard, our journey to serve human and mankind is always on and on. And if you want to sleep like this, take tender care of your patient. Follow protocols as far as any treatment part is concerned, whether it is adenomyosis or whether it is fibroid. And keep my visiting card below your pillow. सत्य परेशान हो सकता है, लेकिन पराजित नहीं. With regards, salute to all the societies who have joined this webinar and Dr. Kanchan Sharma in particular for inviting me to share my views about the subject. And this is law of leopard behind innocent gynecologist, and see the role of medical legal counselor, how he can be useful in any given situation. So please do not hesitate and ask opinion from medical legal counselor in any given situation. So thank you very much. Please do not assume. Please ask if at all any query, if time and chairpersons permit. Thank you very much.
Thank you, sir.
Thank you so much, sir, for the informative session. I would just like Dr. Kiranmay ma'am to just conclude the session. Please, ma'am, over to you.
I'm I don't think I'm qualified enough to conclude this talk by Patel sir. I was listening with interest, very, very interesting and wonderful and very, very important issues for us all gynecologists. A pleasure and privilege to be here, sir, and listen to your talk.
Thank you, Kiran.
And thank you so much, sir. Dr. Madhav, anything else?
Yes,
yeah.
We can just move forward with the next session. The panel discussion, I think we have Dr. Kuldeep sir has already joined us. If sir is ready, then we can just move ahead with the next session. Kuldeep sir.
Kuldeep Singh ji.
Kuldeep is there but on mute.
He was very active just now. आप डॉक्टर कुलदीप सर का सीवी दिखा दीजिए. सीवी करके उनका.
Dr. Kanchan has joined.
Yes, he has joined.
Raj, please show the CV of Dr. Kuldeep sir.
Yeah. So moving ahead with our next session, the panel discussion, ultrasound and fibroids through the imaging perspective. We have a great master in trainer in ultrasound and obstetric, Dr. Kuldeep Singh sir. He's a master trainer in his field of ultrasound, which is so passionate about. He practices ultrasound in New Delhi and is known for his skills in ultrasound in OBGYN and infertility. He has more than 300 talks in national and international platforms. He has been invited to share his academic experience in Japan, France, Spain, Italy, Dubai, Seoul, Dhaka, Kathmandu, Singapore, and Philadelphia. He has received 4 and 3 gold medals in the field of ultrasound. He has authored 16 books on ultrasound in obstetric and gynecology and infertility. His books has been translated into Spanish, Chinese, and Portuguese. He was awarded the Imaging Science Award in the ASCOG Delhi. He is successfully running Sono School, which organizes various training programs in ultrasound and obstetric, gynecology, and infertility. He is going to be launching his latest venture we call We Question and Answers and Learn, which is going to cater to the basics and advanced academic programs. We welcome you, sir, for today's webinar.
Welcome, sir. I have joined your Sono School and wonderfully planned, so devoted, and nothing better than that. You have guided very well each and every person, and all the queries were answered very beautifully by you.
So, Kuldeep Raji, welcome to Society of Gujarat for this webinar.
Thank you so much, sir. Thank you.
Welcome.
We'll start with our panelist. We have Dr. Munjal Pandya, Secretary of Ahmedabad Obstetric Gynec Society. Can I have
Raj,
a screen,
please
Raj?
You can share the screen so that we can see all of them. Yeah.
Oh, yes.
Yeah, he is the assistant professor in AMC MET Medical College, Ahmedabad. He is the honorary secretary of Ahmedabad Society. He has received Shri Daftari Young Talent Award from AOGS and in year 17 and 18. He's co-edited the book Male Infertility in January 2019, winner of Dr. Kamini Rao West Zone Yuva Foxy Oration 2021. And his hobbies are, along a part of this, he's been hobbies with painting, guitar, singing, writing, tennis, and photography. Our next panelist, Dr. Divyesh Kumar M. Patel. He is the secretary of Himmatnagar OBGYN Society. We welcome you, sir, for today's webinar. Dr. Jignesh Modi. He is secretary Porbandar Obstetric and Gynec Society. He is working at Riddhi Hospital since 1986, and he has also worked with Moraji Khekar Thakar Hospital Porbandar and Lady Hospital Porbandar. He has been invited as various faculties in conferences like AICO, Ahmedabad, Lucknow, and UA Foxy. We welcome you, sir, for today's panel discussion. Our next panelist, Dr. Gaurav Gadvi, sir, past president Naryad of Obstetric and Gynec Society. We welcome you, sir, for today's webinar. Our next panelist, Dr. Janil Chikani, sir, secretary Junagadh OBGYN Society. We welcome you for the panel discussion, sir. We have our next panelist, Dr. Satyan Kasabala. He is presently a secretary of Navsari OBGYN Society and a renowned laparoscopic surgeon and fellow of Dr. PG Paul, sir. He's being past organized secretary of SOGO 2012, which was held at Daman, and midterm SOGO 2015. We welcome you, sir. Our last panelist, Dr. Pinky Kataria, madam, director of Radha Swami Multispeciality Hospital, and she is serving as a president Naryad Obstetric Gynec Society. We welcome you, ma'am. Over to Dr. Kuldeep, sir.
Hi, good evening. Thank you. Thank you so much for giving me this opportunity. Thank you, Dr. Kanchan. Thank you, Dr. Patel. It's going to be good fun. So we're just going to start off, and there's going to be plenty of interaction. I have a really nice blend of academic people with me for this. I'll just start sharing the screen.
Sorry
can you
to
all see the screen, and can you all hear me?
Yes, sir. Yes, sir. Sorry to interrupt just in between. As 2 or 3 panelists are still pending to join, I think I invite everyone who are present here to just actively participate till we have all the panelists join with us.
Not a problem. If any of the panelists are not there, anyone, if you can just take in that. This is just basic, and we're just trying to drive home the point to all the delegates as to what all should be done in terms of diagnosis. And that's why Dr. Kanchan has put up this wonderful topic, imaging perspective for ultrasound and fibroids. My esteemed panelists, they've all been introduced: Dr. Munjal, Dr. Divyesh, Dr. Jignesh, Dr. Gaurav, Dr. Janil, Dr. Satyam, and Dr. Pinky. So we're just going to be working on the how to really look in for. So I'm just going to be starting off with a little bit about basics of what all has to be done, so that we are all aware of. You need to be looking at the uterus very carefully, and we need to be looking at the fibroids as well. That's how a normal uterus looks like. We need to be looking at a homogeneous myometrium. We need to be looking at the endometrium. And whenever we're looking in for fibroids, we need to be well aware of this junctional zone. I hope everyone can see the slides, and the video is also working fine. Dr. Kanchan, is it okay?
Yeah. Very nice. Very nice.
Perfect. So you're looking at a nice triple-layered endometrium. Whenever you're trying to look in for ovarian pathology, we should be doing it on a baseline scan. Whenever we're doing it on the uterine, in terms of looking in for endometrial problems, or we're looking in for myometrial or the uterine problems, always a good idea to do it in the mid-cycle or in the luteal phase. We're supposed to be measuring each and every area. That's just pictures of a normal uterus. We have these various fancy stuff where you can look in for multi imaging over here. You can look in for multiple slices. You can make a measurement by vocal. You draw a straight line, you would be missing out on information here. So you can always trace the line so that you can get a proper way. We have 3D to help us, and we're going to be discussing that in the course of the panel discussion, where we're trying to look in for a nice endometrium, carefully looking at the junctional zone and the uterine contour. Normal cavity seen over there. Normal contour seen over there. And we're looking at a normal endometrium. We're not looking at any problems encroaching over there. We're supposed to be seeing the anatomy and the physiology. Ultrasound is a boon. It's really helped us in terms of looking in for. And we know we are supposed to be very careful about submucous fibroids. We have office hysteroscopy, TVS, sonohysterography working for us, various symptomatic treatment that we need to be doing it. And that's the first question. And we have for Dr. Munjal Pandya. I hope he's there. Dr. Munjal, are you there, Ji?
Munjal is in surgery, so I think he'll join once he finishes.
Any one of you, you're most welcome to just take this question. On ultrasound, what modality, which probe would you be using, and what's the reason behind it?
We are using the transvaginal probe. It gives the perfect information and regarding the size, location.
Perfect. So that's how what we're trying to look in for is we could be looking at various possibilities. And why I purposefully put this slide is a translabial scan can also be done. And we do not need a specific probe for a translabial scan. The same probe that you use for a transabdominal, you just need to be wearing a glove, putting jelly over there, deglove it on the transabdominal probe, and it becomes a translabial probe as well. And why is transvaginal scanning much better? Because of the high resolution, because of the high frequency over there. Dr. Kanchan, who all is joined from the panel so that then I know whom to address.
Dr. Devesh is there. Madhav, who other are there?
Dr. Satyan is here. Dr. Divyesh sir is here.
Perfect.
Yeah, and Dr. Jignesh and Dr. Janil sir is joining shortly.
Perfect. So again, we know hysteroscopy would be the gold standard, but yes, initially we need to be looking at doing an ultrasound scan. A pre-operative assessment is required, and today we're going to talk about myometrial free margins and looking for associated pathologies. And we know an abdominal scan is also required in quite a few cases when you're looking at multiple fibroids. When you're looking at the uterus, which is quite huge, because the problem is the overview is poor in a vaginal scan. So we need a good overview. If I need to see, is it pressing on the ureters, I would need an abdominal scan. Dr. Devesh, are you there, Ji? On ultrasound, apart from a 2D, what all, we're just looking at not only two-dimensional images, what all could be there or should be there in your ultrasound machine, which is going to give you more information.
Dr. Devesh, are you there? We have to see the grayscale, color flow mapping. Dr. Devesh, please.
Dr. Devesh is not there. Dr. Kanchan, why don't you just join in?
Yeah, Devesh is there. He needs to unmute himself.
Dr. Devesh, Dr. Devesh sir is there. Why don't you just send in a request to unmute?
Raj, please unmute him. So, Dr. Devesh will answer this question. The answer is very simple, is on the board. Please unmute. Raj, please unmute Dr. Devesh.
Hello.
Yeah, Dr. Devesh, welcome.
Hi, Dr. Devesh.
Yes.
We had a question for you. Basically, if you're looking at on just not a 2D ultrasound, what extra things could you be using on your ultrasound machine to give you a little more information about fibroids?
Grayscale, color Doppler.
Perfect.
And if a 3D 4D machine, then volume sonogram.
You can always use that. So it's basically it's always what you have that you're going to be doing and using it judiciously. If you have a color Doppler, definitely try and do a color Doppler to figure out what all are the indications. We're going to be discussing that towards the end.
Very good.
Dr. Jignesh, that's a question for you on ultrasound. What all are you going to be seeing in the uterus? Basically, what all are the things that you need to be taking care of?
Dr. Jignesh, are you there?
No, ma'am, he is not present at present.
I think so he's in a surgery. Dr. Kanchan, Dr. Devesh, anybody of you can take that question,
on
please.
endometrium, we have to see the thickness, morphology, endometrial myometrial interface, what is there in the cavity, what is there, myometrium, we see whether this is homogeneous, what is its echo pattern, whether there are a few masses or heterogeneous, or there may be some opacity, and vascular flow also we see.
Perfect. So that is what you're going to be doing on the uterus. Why I always say you need to start from the basics. Do not straight away start off by let's do a 3D scan. You need to be clear. When you decide upon a machine, always try and ensure that that machine has a good 2D. Because if the base is not going to be good, the whole thing is not going to be good. So in the musculature, you're going to be looking in for fibroids, adenomyosis, and the various other things. Common myometrial pathologies, you could be looking at that. And today we are going to be focusing on fibroids. Dr. Gaurav is there.
Dr. Gaurav is there, Dr. Madhav?
No, ma'am, no, ma'am. We have Dr. Satyen sir with us.
You can ask to Dr. Satyen.
Yes, all fibroids are not as you suggested as symptomatic. Most of the time they are asymptomatic until unless they are very near to the endometrial lining, or you can say it's affect the infertility and may affect the menstruation problem. Otherwise, most of the time the fibroids are asymptomatic.
Perfect. So it's commonly an incidental finding where we look in for, we're doing a routine scan and we figure it out, or she's come for something else and we figure it out. We could have intrauterine, extrauterine, or we could have diffuse uterine leiomyomatosis. That's a question for Dr. Janil. Is Dr. Janil there?
No, sir.
Not a problem. What I'm going to do is, rather than focusing it on one, whoever panelists are there, you're most welcome. Please keep answering so that I don't keep on asking for the names and whether they're there or not. Whoever is there, you can. And if there's a particular question focused on to you, you can. What are the common symptoms with which a fibroid can present? Any of the panelists, please.
Menorrhagia, dysmenorrhea.
Perfect. There could be intramenstrual bleeding. There could be a feeling of fullness. You could be looking at, she could be feeling something hard. There's so many times when she says, I'm feeling something hard, it appears as if I'm getting more fatter and it's not coming down. And you figure out there's a huge fibroid. There could be because of pressure symptoms, a low backache, constipation. There could be discharge, problem of urination, or an increased abdominal distension.
Many times this may be asymptomatic, maybe an accidental finding on ultrasound.
Absolutely.
Depending on the site of the fibroid, there may be features.
So now we're looking at scenario one. The patient has been following up for a fibroid for many years. She's now come with a pain lower abdomen. It's not that she's come with certain, she says, I'm having pain lower abdomen, and we've been following her up for so many years. What all, apart from, let's say, yes, you have a fibroid, what all should be in the history that we should be asking her for?
Maybe I'm asking for the menstrual complaint, whether it's increasing or decreasing. Second thing, whether it's associated with the pain or not.
Absolutely.
Or anything related with the urinary symptoms, whether there is a stress incontinence or pressure symptoms on the rectum, maybe she's constipation.
It's quite possible that the pain is not because of the fibroid. We need to keep that also on. So whether is it a loin to groin pain, does she have any fever? Does she have any radiation as such? Any urine test of pregnancy done? If she is in that particular age, has she missed out on her period? So all those things are going to really help us out. Now, the same patient, and what all other possibilities that we can think of in terms of a pain, lower abdomen, in terms of for the fibroid? What all can you think
Pinky
of?
is there. Dr. Pinky.
Good evening.
Thank you.
All
Yes,
other
Dr.
possibility for the degenerative changes in the fibroid. It increases in the size of the fibroid, causing the pressure symptoms. There will be dull chronic pelvic pain and low back pain also there. But sometimes this pedunculated fibroid, it causes, it has a twisting of that fibroid. That may be
Very good.
also one of the reason of the previously present fibroid.
Excellent. Perfect. So that is what we really looking in for, that if it's the fibroid, what all possible reasons could there be? We could be looking at a hyaline degeneration, a cystic degeneration, myxoid degeneration, or a red cardiac. It's not that I can take out these histopathological diagnoses on the ultrasound, but we need to keep that in mind. Same scenario, we're looking at this picture and we are looking at this as the fibroid. So what do we really looking for? How do we really describe this picture? It's not homogeneous. What are we looking at over here? Dr. Pinky, you could answer that if Dr. Munjal hasn't come.
This is a clear-cut capsule, that is a clear margins of the mass is same, and it is almost intramural and almost protruding to the subserous on the fundic region. Almost, I could not make it the site, but it is definitely a FIGO classification type 6 or type 5. And
we're going to be coming on to that. But what do you say about the echo pattern? She's come with pain, abdomen. Do you feel there's something in this fibroid?
There is a mixed type of heterogeneous, echogenicity, and some sort of ecotextures.
We're looking at black, white, gray,
black and
everything.
white, everything.
So we'll be looking at degeneration.
Degeneration.
Absolutely correct, Dr. P. So
we are seeing irregular margins of the fibroid.
Sorry.
The margins of the fibroid has become irregular in previous picture.
Absolutely. Correctly said. That's how you're really looking at. Dr. Devesh is here with us. Why would you feel that what is the reason behind the degeneration in the fibroid?
If fibroid is for a too much long time, then it start degenerating.
Absolutely. And when it just increases in size too much, it just outstrips its own blood supply. So that is the reason. And then what happens is it shrinks down. There's pain, especially in pregnancy. We've seen so many times because of increased blood flow towards the uterus. All fibroids or seedling fibroids also become a little bigger. We can, if it's growing too rapidly, we can look in for a degeneration. Perfect, Dr. Devesh. So we're looking at a general scenario now. Dr. Jignesh, has Dr. Jignesh joined in? What all should you be seeing about the fibroid? In terms of, let's say, we're reporting, what all should we be thinking of? If Dr. Jignesh hasn't joined, anyone, or Dr. Devesh, Dr. Bhavik, anybody, whoever is there, you're most welcome to answer that.
Its location is okay.
I would like, yes, ma'am. Pinky, ma'am, please. Yes.
Okay. Its location, size, type, co-pattern, and vascularity. Apart from that, how many fibroids also sometimes always present with the multiple. So reporting of the fibroids should be include is it a homogeneous or heterogeneous in echogenicity? It should be a well-defined or not. Number of the fibroids, as I already said, location, size, and site penetration where it is, and mapping and vascularity. There is a circumference, equidiameter, or the homogeneous or heterogeneous distribution is there or not. Whether there is any type of degenerative changes can be seen in the fibroid. Yeah. Reporting also important to have a standard report format for any scan that first describe the ultrasound features of the lesion or organ and then derive the diagnosis.
Very good.
Very correctly said, Dr. Pinky, that you need to be very, very clear of what all are you going to be mentioning about a particular fibroid. Fibroid, this is the size, does not give any information. How is someone else going to be comparing that? So a complete thing has to be, if there are multiple fibroids, 4 of them, please mention all of them. Dr. Devesh, would you like to add something in that?
No, sir.
So that is how you're really looking at. Then is Dr. Gaurav joined in? Otherwise, anyone if you can answer. What exactly is fibroid mapping and why is it so important? Why we get referrals for, please do a fibroid mapping.
Correct location of the fibroid can be defined by its position in the uterus, involving upper, middle, or lower part of the body of the uterus or the cervix. It involves the anterior, posterior, or the right or left lateral walls, or its position penetrating according to the FIGO classification as type 0, 1 to 7, and its size preferably. So it all is important for the management of that fibroid.
So all 3 dimensions, it's not one dimension. Because the fibroid is not always going to be circular, that it has to be just the diameter. All 3 dimensions, both the planes have to be at 90 degrees, and you need to take all the 3 dimensions at 90 degrees to each other. So what is very, very important, Dr. Devesh, if you would like to add on from here, the correct location, how are you going to be defining it?
No.
We're basically trying to look in from the distance from the endometrium. So that is how we, so how far away is it from the serosa? How far away is it from the endometrium? Is it enveloping here or is it enveloping there is what is important.
If we specifically talk about fibroid affecting fertility, we should definitely see whether it is affecting the fallopian tube area or is it affecting near the isthmus or cervix part. So in that manner, it will definitely be affecting the fertility aspect. So that's why we really need this mapping.
Absolutely. Perfect. That's the correct answer. I don't know. I think so. Everyone is joined in with Dr. Bhavik Khatri's link. So everyone is appearing to be Dr. Bhavik only. So if you can just rename yourself so that we know who all have joined in.
Yes.
So we'll be looking at multiple fibroids. This patient is a follow-up case of infertility. We're looking at this picture. And what do you feel is the FIGO classification? We'll now go on for a little bit of FIGO classification. That's bang in the center. That's the 3D picture. That's the endometrium. So what sort of a FIGO classification would this fall into? Any one of you, G, please. Any one of you, most welcome. So basically, it's more like a fibroid polyp, completely in the cavity. So what would it be?
0, but
pedunculated intracavity.
It was not showing like pedunculated.
That's because we don't have a sonohysterography picture, but it was completely within the cavity. So it could be either 0 or 1, likely to be 0 because we're looking at completely inside the cavity. So that's the FIGO classification. Any one of you wants to just shed a little light on that, you're most welcome. Any of the panelists who could just tell the delegates about the FIGO classification?
0 is pedunculated intracavitary as seen in this diagram. And if it is less than 50% or equal to 50% intramural, that is in this diagram, that is number 2. Less than 50 is number 1. Number 3 is intramural. That is it contacts endometrium. Endometrium se touch karta hai and 100% intramural. 4th is totally intramural, doesn't touch endometrium, and 5th is grade 5th is subserosal, that is beneath the serosal, more than equal to 50% intramural. And 6th grade is subserosal, less than 50% intramural, like shown in diagram. And 7th is subserosal pedunculated, that is this is a peduncle outside. And number 8 is other specified area, like in cervix or parasitic. That is
what you're seeing over there, that's Dr. Kanchan has absolutely explained. If you're looking at submucous fibroids, you have 0, 1, and 2. 0 is completely inside the cavity with a pedicle over there. If you're looking at more than 50% inside the cavity, this is going to be 1. Less than 50% in the cavity, more than 50% in the myometrium, it's 2. That's correctly said by her. If it's just touching and it's not really displacing, and it's more of interstitial. This is 3, not touching the serosa, not touching here. It is 4. Less than 50% is protruding out. It's 5. More than 50% of the fibroid protruding out. 6. With the peduncle over there, 7. So 5, 6, and 7 are subserosal. 0, 1, and 2 are submucosal. 3, 4 are interstitial. That's how we need to remember. So if you have it in the clear-cut guidelines, you'll be able to give a fantastic report. Now, this is another patient of menometrorrhagia. And we're looking at this sort of a fibroid. We're looking at, this is the endometrium. That's the fibroid, which is less than 50% in the cavity. In a FIGO classification, which one would that be? It's more in the interstitial, less than 50% displacing the cavity of the fibroid.
Plus 2. 2.
3.
This would
I mean,
be
2.
This would be 2. Yes.
2.
Yeah.
Now we have an asymptomatic fibroid. This is not troubling at all. That's the endometrium you're looking at. That's the fibroid that you're looking at. It's not displacing the endometrium or the serosa. What classification would this be? So we have 0, 1, 2, 3. This is touching. This is not even touching. So this is 4. Absolutely bang in the interstitial area. Is there any questions for our panelists, or if there's any question you all want to ask for the delegates, just please type it there so that we can take those questions as well. Now we're looking at an infertility patient with a submucous fibroid. We need to be doing a hysteroscopy. How much would the Lasmar's classification help? We've now started doing a Lasmar's classification or the pre-hysteroscopic classification that few people have started to ask for. This is just for the delegates so that they understand. We have these various techniques. We have the ultrasound, which tends to tell us the myometrial free margin. This is what we're trying to figure out, that if there is a fibroid, how much is a normal myometrium lateral to the fibroid? That's a question for you all again. We had the Wemstecker classification, which we're no longer using. Lasmar's classification, which few of us are using. Otherwise, we're following the FIGO classification. Yes, any one of you can just throw some light on the Lasmar's classification. We're basically trying to look in for, if you see this fibroid over here, this is the endometrium and that's the fibroid. That's the fibroid. So in the Lasmar's pre-surgical classification, we're trying to look in for a step W. Any of the panelists want to take that question? You're most welcome, Ji. So we're looking at size of the fibroid, the topography, extension of the base, penetration into the myometrium, and which wall. So depending on the size, less than 2, 2 to 5, or more than 5, we give a score of 0, 1, and 2. Topography, whether it's in the lower portion, middle portion, or the upper portion. Extension of the base, less than 1/3, 1/3 to 2/3, or more than 2/3. Penetration, completely in the cavity, more than 50% or less than 50%. That's more for a hysteroscopic thing. And if it's on the lateral wall or it's in the middle. We add these scores, 0, 1, and 2. And if a score is 0 to 4, meaning we require a low complexity hysteroscopic myomectomy, 5 to 6, we could be requiring a GnRH. There could be a 2-step, 7 to 9, a hysteroscopic myomectomy is indicated. Our hysteroscopic surgeons are getting braver and braver, and they're much more advanced now. They tell, okay, just tell us how much is the myometrium, normal myometrium lateral to the fibroid. We'll be able to take that out. So that is how we just keep following it up. So that's another scenario where we're looking at a patient with multiple fibroids. Patient wants to retain the uterus. Would the color Doppler help in this case or not? A question for you all, Jay.
Actually, color Doppler will help in it to see that, because we see the vascularity, how is the peripheral rim, and circumferential and intralesional vascularity can see here. Depending on that, we can plan or we can plan for the uterine artery embolization in these cases. Degree of vascularity is very important in these cases.
Perfect. So that is how we are going to be doing that. So you need to be looking at how much is the vascularity. There we're looking at, if there's a degeneration, you could be looking in for intralesional as well. Otherwise, it's normally circumferential. So you're looking at, that's the degeneration, and that's why you're looking at intralesional vascularity as well. We have these various Musa classification where we have it for no color, minimal vascularity, moderate vascularity, or abundant vascularity. Not going to go into all those details. I think so. Our panelists are stuck in a surgery. Now, that's another question we've looked in for. Where is Doppler helpful? Is it mandatory, or do you feel a 3D scan is a must? Will that help us?
Yes. Yes, it is useful.
It would help us. How would it help us, G?
Evolved so quickly and now has it all from
If you could just keep answering the question, G, I'll just join you in a second.
By providing the multiplanar imaging, 3D ultrasound not only gives an additional dimension to the uterine scan, but also provides a similar quality and less expensive alternative to MRI. High-end machines now, if people are using, that gives them much idea about the site size and mapping of the fibroid by the 3D. And of course, 4D added. Also volume rendering also there.
Yeah. So we need to have a 3D scan which can help us. It's not that it's necessary, it's a must, not at all. It definitely gives us a little added advantage by looking at multiplanar images. If you see over here, you can nicely see how it is. We have automated volume measurements. We can look in for multi-slice imaging. Tomographic ultrasound imaging is going to give us this more information.
I would like to add on this that if a small fibroid is residing behind the big fibroid, sometimes with the help of 2D it will not be visible, but with 3D, such small fibroid hiding behind the big fibroid will also be visible.
Absolutely correct. And that is what, see what happens is, you're looking at a SAD section, you're looking at an axial section. A coronal section is not possible on a 2D unless and until you're looking at a retroverted uterus and on a transvaginal, it could give you a semi-coronal section. But 3D, you can always rotate the complete picture and get it. Absolutely correctly said, Chief. We're looking at a large fibroid. We're not sure of the endometrium over here, but the moment, and we're not sure of the echo pattern. You can see nicely, we're looking at the endometrium and we're looking at the fibroid over there. So these small steps is what really is going to be helping us to achieve these. Again, a question which we all are too keen on, okay, let's go and quickly get an MRI done. Are there conditions where an MRI would be helping?
Yes. The MRI improves the patient selection for who should receive the non-surgical uterine fibroid embolization to kill the tumors. And research also showed that interventional radiologists can use MRIs to determine if the tumor can be embolized, detect alternate causes for the symptoms, identify pathology that could be prevent the woman from having UFE and avoid ineffective treatments.
So that is what. See, what are we trying to do? We're going to be just having a few slides on the medical management as well, where we're looking at uterine artery embolization. Ultrasound is not going to be giving us too much of information for that extent. MRI is going to be helpful. Where you're looking at multiple fibroids that even on a 3D, it's not very clear. That's where MRI is going to be helping us. Now we're looking at a patient who's come with intramenstrual spotting, and we're looking at this sort of a lesion. We're looking at this lesion over here.
This is very common in our day-to-day practice.
Absolutely. So what do we really think on that? What is this? And how
Either
do we
endometrial polyp or fibroid polyp.
So this most likely is an endometrial polyp. And how do we differentiate it from a fibroid polyp?
You can go for the SSI, tonosalpingogram especially, and particularly.
Absolutely, that would, but otherwise we have the echo pattern helping us. We have the color Doppler helping us.
Yes.
So if you're looking at an echogenic area, that's the endometrial polyp. A fibroid polyp is hypoechoic. If you're looking at a single vascular pedicle or barely two of them in some cases, that's an endometrial polyp. But if you're looking at multiple vessels inside it, it's more of a fibroid polyp. So that's how you're going to be differentiating. Then what are the indications where you would be looking at a uterine artery embolization in fibroids? We have those two particular types. Any one of you?
Symptomatic fibroids patients wanting to preserve the uterus.
Absolutely. So that is where a uterine artery embolization. There are a few people who are not fit for surgery. You would be. These are strong indications. Less strong indications where we're looking at pressure symptoms. Just so that our whole idea is to shrink this so that the pressure symptoms also reduce. We're looking at somebody who's 47, 48 years, well, either doing a hysterectomy or they're too scared for going in for some sort of a surgery. We could be thinking on those depending on what are we looking at. Then we have the MR HIFU, the frequency ablation over there. In which do you feel we would be indicating for an MRI?
I would like to interrupt you here.
Please.
That we are talking in previous case, we were talking about devascularizing the fibroid with the help of uterine artery embolization.
Yeah.
So how common is this treatment opted? Number one, uterine artery embolization, and number two, laparoscopic uterine ligation. I have seen, I belong to periphery. I've seen very rare cases, or rather no cases of such treatment being opted. I would like to know that how frequently this treatment is being opted.
Again, I'm not a gynecologist, I'm a sonologist. These two slides were just to help out. But what I've seen over here is in the major hospitals, there are plenty of people who are opting for this. How successful is it? In fact, the laparoscopy and the hysteroscopy has become so comfortable nowadays for the patient that they opt more for that. So that definitely
excellence in this work is also required, particularly the interventional radiologist.
absolutely.
And I think in metro cities these facilities are available, and if it has to be done in emergency, like where bleeding is there and need to go for a patient is not fit for the surgery and need to go for that interventional radiological procedure. It is also very
AV
difficult.
malformations, one indication that we always know is that yes, in that case, if uterine artery embolization is being done, it is life-saving.
Very right.
Absolutely, absolutely. See, again, it's not that straight away somebody comes for a fibroid, we tell them, okay, you need to be going. That is why these are the less strong indications. But yes, things are there. There are many of these who are looking in for. We have the MRI, HIFU thing. That is also, it's not that it's so prevalent that everybody, even in Delhi, is getting it done. There's so many of the laparoscopic surgeons who still feel that is much more comfortable in terms of doing a surgery, doing a hysteroscopy. There are plenty who would like to put in a marina and see what the response is depending on how much So
Absolutely.
I won't be knowing about the treatment portion, but yes, various things have to be told to the patient. The options have to be available, and it's for the patient to decide what all should be done. Anything the panelists want to add, you're most welcome. Please do that.
MR HIFU is also not reachable therapeutic options for periphery, even in the much bigger cities.
Even
also
in the bigger
it
cities,
is,
this is very less frequently done.
and also there are another good options rather to go for this. And MR HIFU also has some side effects, like if it has been in energy sources as inevitably injure the intestine, vital structures, that might be one of the I think it is a complication. So unless and until patient wants it, then and then we are just considering for that. But I have never sent any patient for MR HIFU, even though we are working at some good stage. We know that.
This started with the big bang when MRI HIFU was there. It started with the big bang. There were plenty of
one
things
probe. I think one probe they are using is costing around 1.5 lakhs or something, and multiple probe has to be used to do this fibroid to I mean making it emulsifying.
And there are plenty of ifs and buts to it. So that is why it's not that prevalent now. It started off with lots of promise. It's not that prevalent.
Is the being done in AIMS or what are the centers? Yeah,
it's a Bombay centers. I know that is HIFU somewhere. I think.
Otherwise,
one Bombay center
all over India.
Very few. Yeah.
Fine, G, perfect. So that was more of a practical discussion swimming across. I would want each and every panelist to just add in a word for the delegates, so that whatever you feel would be an expert advice for the delegates for diagnosis of fibroids, the imaging perspective. One by one, if you could just do that, and then I'll sum it up. G. Dr. Pinky, you can start off, G.
What, sir? I didn't hear about it. I mean,
yeah, we can hear you. Yeah.
You can hear me, but I somewhat I didn't have questions. I mean,
now this is we through with the panel. It's just one last piece of advice or last piece of discussion that you would like to take home message for the delegates.
See, I would like to say that it should be the treatment or the diagnostic purpose or mapping is what we have discussed earlier, that mapping is nowadays almost done with the FIGO classification, and treatment according to the FIGO classification and the requirement of the fertility, patient's fertility. And still for the fertility requirement, myomectomy is a routine procedure. It is almost 100% accepted by the patients. And hysteroscopy, added hysteroscopic myomectomy, or either laparoscopic myomectomy. And if patient is not required any fertility, still hysterectomy is the most accepted method in India, and particularly in peripheral center also. I
would like to ask one thing, that how about some of the medical drugs being offered for the treatment of a small size fibroid affecting or rather giving pressure to the cavity. So that is low dose mifepristone, and one or other few other molecules are also available in the market that are claimed to affect to reduce the size of the fibroid. Any experience?
Uliprestol and GnRH analogs and all are still I have used in few of my patients, particularly my clinical experience. I don't have a much good result. Previously, I was using the GnRH analog previous to the surgery, but I didn't find good for even after it gives additions to fibroid to the intramurals and gives difficulty in the surgery. So I stopped to give pre-operative GnRH analog in large fibroid too. So ultimately, it's up to our choice, and our facilities available surrounding us will decide the management and definitely the requirement of the patients.
Okay.
Very right. Because
any other take-home message by any of the panelists? Who else is there? Dr. Devesh, I think he got disconnected. Anybody else? Dr. Kanchan, if you can give in a take-home message, and then I'll sum up the whole panel.
So this was a wonderful panel discussion as usual by you. You give us a very important and brilliant pulse of wisdom. You very rightly described the whole of the fibroid by the ultrasound perspective, and as such Figo and Lasik classification and its application, and even the perspective regarding its treatment. So thank you very much.
Thank you, Ji. What I would like to let all the delegates know is, whenever you see a fibroid, you have to give complete information. Where exactly is it located? Is it in the corpus, in the cervix, in the fundus, anterior wall, posterior wall, right wall, left wall? How far away is it from the endometrium, or how far away is it from the serota? What is the size? What is the echo pattern? What is the vascularity like? If you have a 3D machine, do a 3D, give a 3D picture as well. If it's a single fibroid or the multiple fibroids, always and always make sure. There's another thing, when there are multiple fibroids, irrespective of whenever you're doing scanning a patient for the first time, it always has to be a transabdominal scan so that you do not miss out on anything which is higher up. You write everything is fine, and a small pedicle, and it's a pedunculated, this subserous fibroid, fundal subserous fibroid, you'll not be able to see on a transvaginal, and you'll be making a mistake. If there are multiple fibroids, irrespective of, always start transabdominal and transvaginal. Sometimes you'll not be able to figure out where exactly is the endometrium. Trace it from the cervical canal and then go up, and that's when you'll all of a sudden realize that the endometrium is pushed on one side, and that's how you're going to be giving a complete information. Are there any questions on the chat box, in the chat box in the question answer session? We can answer those. Otherwise, that's all from the panelists and myself.
Are there any questions, Dr. Madhav, in chat box?
Not at present, ma'am.
No questions.
Perfect. So that means
sir
we
is a
confused
perfect teacher.
everybody so much, or we made things so simple.
So I think everybody understood, and all the fundas are clear. So there are no question at all. There are 3 cheers, and big clap for Dr. Kuldeep and all the wonderful panelists and the chairpersons and all. So my sincere thanks. Official vote of thanks will be taken by Dr. Madhav, but my sincere thanks for joining us and giving us a word of wisdom, pulse of wisdom, and blessing us, Dr. MC Patel sir, Dr. Jadhav, Neeraj Jadhav sir, all the guest of honors, and all the wonderful chairperson she has joined. Thank you. And Dr. Kuldeep sir for a wonderful, wonderful moderation and very good insight of the topic. Dr. Madhav and Dr. Bhavik, 2 young,
yes,
very wonderful coordinator I have ever met. You have done a wonderful job and much of effort to put this webinar success. Thank you very much, and thanks our academic partner Shield Connect, who were there all the time and always helping us, Raj, Suman, and all the Shield Connect. Dr. MC Patel is still there to bless us. Your topic was very wonderful and give us a great insight the topic and how to manage the medico-legal. So your slides, I should praise, wonderful. From where you take all the very good videos and all the presentation, it's worth appreciation. And the official vote of thanks will be given by Dr. Madhav.
Yes.
Thank you, Dr. Bhavik, for really pursuing all of us and making sure that things go smoothly. Thank you, Patel sir. Thank you so much. Thank you. Thanks, Kanchan. Thank you so much.
Thank you, sir. Thank you so much. It was a very informative and a very precise and very basic knowledge which you have given us everyone through ultrasound and fibroid and adenomyosis. Now I would like to thank all the guest of honors, the chairpersons and the panelists and the moderators present today for the webinar. It was a very nice and very informative session. I would like to thank our partners, Shield Connect and Mr. Raj and Mr. Suman, and my coordinator partner, Dr. Bhavik Khatri sir, to help out and coordinate very well with everyone. And the webinar went very smoothly. Thank you so much, Dr. Kanchan Madam and MC Patel sir, to give us this opportunity and make this webinar a successful one. Thank you so much. Thank you once again.
Thanks, Madhav. Thank you so much. Great.
Lovely webinar. Cheers to all of us.
Thank you so much, sir. Thank you so much.
And again, request for your vote and support.
Yes. We appeal on behalf of Dr. Kanchan Sharma Madam and Dr. MC Patel sir that as they are, Madam is contesting for the committee. So once the voting lines opens in April, please everyone vote for her for the chairperson. Thank you so much.
Dr. Madhav, I request from my side also. Thank you.
Yes, Dr. Devini, we will not forget
Dr.
you.
Kanchan Sharma for breast committee, Dr. Kiran Mai
for no to violence against.
No to violence against the
really wonderful sessions today. Really enjoyed being with the program. Thank you, Dr. Kanchan, once again. Kuldeep sir, it was
Thank you, Dr. Kiran, for joining.
Thank you, Dr.
Sir is always very wonderful.
Yes.
Anytime I ring, I am in a problem in the ultrasound or any, he is very helpful and wonderfully. It's a brilliant opinion, always very helpful to each and every person.
Thank you.
God bless and so many good wishes. Thank you.
Thank you, Ji. Let's take your leave. Let's enjoy the evening. Bye-bye. Take care. Stay safe, stay healthy. Thank you, all of you. Thank you. Bye-bye. All the best.
Thank you so much. Thank you so much.
Goodbye to everyone. Goodbye.
Okay. Thank you, Shield Connect.
Thank you, ma'am. Thank you very
Raj,
much.
and thank you, Suman. Raj,
Thank you very much.
we are always disturbing you just to prepare the flyer for the PPT and all. Always you were very responsive and very well responded us. Always.
Thank you so much, ma'am, for giving us this opportunity.
On our behalf. Thank you very much. Thank you so much. Thank you so much. Okay, should we leave the session?